Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast. So today we're meeting with Bethany Roper. Beth is a doctoral researcher exploring dementia in forensic mental health settings, and she's doing this at the University of the West of Scotland. Beth is a graduate of MSc Investigative and Forensic Psychology at the University of Liverpool, where she conducted mixed methods research exploring honour-based abuse. And she previously worked at Broadmoor Hospital. Hi.
Hi, thanks for having me on the podcast.
Hi Bethany, really nice to meet you. I'm glad that you could join us today. Can you tell us a bit about how you got interested in exploring dementia in forensic populations?
Yeah, so the PhD that I'm doing, it was advertised, a funded PhD, so it was advertised as dementia in forensic settings. So I sort of applied and was accepted for it. And I think what drew me to it was, I think when we think about forensic mental health hospitals, we think of the more sort of acute psychiatric disorders like schizophrenia or things like personality disorders. And it just really intrigued me thinking about dementia, because we do have an ageing population and an ageing forensic population. So obviously we're going to see these kind of age-related health conditions a lot more frequently. So I was quite interested to research more about it and understand more about it. Especially when forensic settings, they are tailored to those sort of acute conditions. And when we think about how individuals are released from forensic settings, they're in there indefinitely, and they're released based on, clinical judgments of treatment progress or risk reduction. So I was quite interested to see how that would apply to a condition that isn't necessarily clinically treatable, and it's also progressive. Yeah, I found it quite interesting, and I just sort of wanted to apply, and I was successful. And I'm about halfway through, so I've been researching it now for a year and a half.
Brilliant, thank you. And can you tell us kind of like what's the current state of play in terms of what we know about the experience of people with dementia in secure settings?
Yeah, so at the minute there's really not much research looking at dementia in forensic settings specifically. There's been research in prisons, which is useful because there are similarities, but obviously there are differences in forensic settings. So at the minute we don't know much about how dementia is being approached in forensic settings. In terms of prevalence, the few studies that there are have focused on prevalence, but still it's really difficult to identify dementia. It's unlikely that you'll get actual diagnosed dementia, because dementia is hard to diagnose anyway. Within forensic settings, there's quite a lot of barriers to identifying it. But in terms of prevalence, there has been studies and rates have been found really a big variation between 0 to 80%. But if we look at older samples, I think we see about 20 to 50% of people have suspected dementia. And by older, I'm talking about 50 plus, because older is classified a lot younger in these settings because they're more vulnerable to health issues. So prevalence rates are about 20 to 50%, and that's a lot more than we see in the general community, where we see dementia in about 6 to 8% of over 65s.
Gosh, it's quite a dramatic difference, isn't it, in terms of prevalence? And is there what's the information been from prison populations that's been relevant and interesting? Because I guess that's probably informed some of your thinking about your PhD.
Yeah, it's the same. So I just mentioned there's sort of barriers to identification of dementia, and they're similar across prison and forensic settings. So those barriers are things like overlapping symptoms with other disorders, so like schizophrenia, personality disorders. There's lots of different types of dementia, but you'll see obviously things like schizophrenia, that's a condition that impairs cognition, and dementia is impaired cognition, so there'll be overlapping symptoms. Also with individuals that do have these other comorbid psychiatric disorders, they'll be on lots of medications, and some of these medications can impair cognition. So the prison researchers found that staff can have difficulties distinguishing between dementia, other disorders, and drug-induced states. Also, similarities between forensic settings and prisons is they're restrictive environments. So typically, obviously, there's different types of dementia and it will differ between people, but typically, early signs of dementia are impairments in these more higher, like complex activities. So things like money and medication management, driving, doing big shopping trips. Obviously, prisoners and forensic patients aren't engaging in these activities in these settings, so it's sort of a missed opportunity to notice these early signs. And it's not usually until the more advanced stages where more basic activities like bathing, eating, walking about become impaired. So there's a missed opportunity for early intervention. But also, research has found in prison studies that staff really aren't trained in dementia, which is another barrier to identification as well. And if there is sort of training, it's usually from sort of their education before going into forensic settings or prisons. So they're looking at, in this training, more purer forms of dementia, and they're not looking at it in the forensic context. So the training that they do have, they're not able to recognise sort of the overlapping symptoms or the forensic context. So that's sort of the state of the prison research, and I think that's quite applicable to forensic settings.
Yeah, just as you were talking, I was just thinking about how in prisons probably there's underdiagnosis in terms of there's much less access to health professionals in prison, and also it can be easier to go under the radar. You know, in a hospital setting would be an expectation to be interacting regularly with staff, whereas in a prison somebody could just keep their head down and have minimal contacts. I can imagine it's even harder to diagnose it there.
Yeah.
What are some of the unique challenges faced by elderly patients with dementia in high secure settings?
I think in terms of unique challenges, like I mentioned, the identification is quite unique because of the restrictive setting. But also, I think forensic patients with dementia, they face sort of like a triple stigma. So they've got the stigma about having a mental illness. You know, you've got sort of these beliefs that mental illness equates to dangerousness or unpredictability. They've got the stigma of having a forensic label, which, you know, when we're looking at that they've got dementia in a forensic setting and you're looking at alternative placements like dementia services in care homes or things like that, having a forensic label can really act as a barrier to getting them to these different places. So that's, you know, another sort of stigmatising label that they've got. And now they've got this stigmatising label of having a cognitive impairment or dementia, so they might be seen as too cognitively impaired for mental health rehabilitation, and there might be sort of therapeutic nihilism, like beliefs that they can't be rehabilitated. So I think that's quite a unique challenge. Also the challenge of the environment, not just in terms of identification, but in terms of not being very suitable for dementia patients. So in national clinical guidelines for general dementia care, there's an initiative to make environments more dementia friendly. And a dementia friendly environment is one that's like you'll see on dementia units in care homes. It's very homely. It's like home-like. There's sofas. There's lots of soft furnishings. There's lots of artwork. Their bedrooms are really personalised. They've got lots of sort of relics to remind them of like their family and their history. And in a forensic setting, it's clinical. It's completely restrictive. There's sort of locked doors, secure perimeters, and that can be quite distressing for patients with dementia. And obviously, all the wards look the same. They might have trouble identifying which door is theirs to their bedrooms and stuff. It can be quite sort of disorientating and confusing and quite stressful. So I think that's another unique challenge as well.
Yeah, thank you. And how does being in a secure environment impact the mental health and well-being of elderly people with dementia?
Yeah, I think that's sort of what I was just mentioning about the environment. It can be quite distressing without these sort of dementia-friendly features. And if a patient with dementia becomes distressed, they might sort of that their communication is different to like a typical individual. So in like dementia literature, it's referred to as like different terms for it, but challenging behavioural and psychological symptoms of dementia. In Scotland, we call it stress and distress or distress behaviours because we see it as like a form of communication. But these sort of behaviours that we'll see is aggression, agitation. They might be wondering about or repeatedly asking questions and things like this. And this shows that sort of the environment isn't very supportive of the mental health and well-being. And I think this is something that we would see quite frequent with patients living with dementia in forensic hospitals because it's not a dementia-friendly environment.
Yeah, I was just thinking as well about the tendency for people with dementia there can be a tendency to become more paranoid, can't they? And if you're in an environment characterised by quite a lot of hostility, then it would be quite easy to become very distressed by that.
Yeah.
When you contrast that with when people are in residential care homes where there is this emphasis on support and warmth and nurturance, it's quite a contrast, really.
Yeah, I think, like just as a hypothetical situation, but imagine you've got like a forensic patient in a hospital and they don't even remember why they're there. They don't remember that they've committed an offence I think it can be quite distressing and it probably could induce some paranoia as well, yeah.
Beth, can you tell me why you chose to look at patients in secure hospital settings rather than in prison?
Yeah, I think for one, the research in forensic settings is much more limited, so I think it's like a gap that needs to be addressed. And then from a personal point of view, my background is in forensic settings, not prisons. But I also think I'm quite interested in like the ethics and the human rights side of this. And obviously, there's probably nuances, but within prison you've got a leave date. But within forensic settings, you're there until some clinical team decides that you're risk-free or like your risk has been reduced and you've progressed. So I think within forensic settings, that's sort of why I was quite interested in that, because obviously if this is a progressive condition and it's not curable, I'm quite interested in understanding how we can sort of move them through the system and take them to those lower security levels or back to prison or back to the community or wherever it might be.
Thank you. Yeah, I'm still interested there because there used to be a prison. HMP Kingston used to house older prisoners, didn't it? But I think that closed some time ago. I don't. What happens to them now? Do you know, Naomi or Beth?
No.
Okay.
I know when I was at Whitemore, there was talk of they were setting up obviously life sentence prisoners don't have a automatic release, so there was talk of creating a specialist service for them, but I don't know how far that got.
Oh well, perhaps that's something we should look into, really. So Beth, what measures are currently in place to address the needs of these elderly inmates with dementia?
I think that's a difficult question because there's not much research, and because I'm not in a practitioner role, I couldn't sort of comment on it, and I'm still in the really early stages. But I think with conversations that I've had with forensic staff, there's not really any sort of standardised care pathways currently, and it's sort of dealt with on a case-by-case basis, and that's also what's happening in prisons. And I know from like Care Quality Commission reports and things like that in forensic hospitals, there's been attempts at sort of introducing environmental modifications to help patients with dementia with sort of independence. So, for example, that will be in like putting on the walls like pictorial aids, like calendars to let them know what the day is, what the weather's like, what's in the news, things like that. And also, I think within prisons and forensic hospitals, they've also done things like putting bright coloured tape around the doors of patients' rooms so they can identify which rooms are theirs. But in terms of like specific care, like psychological therapies or social therapies, I'm not actually sure what's currently happening, and that's something that I'm hoping to find out with the research. There is one intervention or program that I'm aware of in America though called, it's actually a prison, it's California Men's Colony Prison in California, and they have this specific program dedicated for inmate patients with dementia. So they have like these environmental modifications and they have specific group activities for dementia and things like this. And one unique thing that they've got, which I don't know how transferable this would be to forensic settings, but they have something called the Gold Coats program, where they get cognitively healthy inmates and they train them, and then these inmates sort of support those with dementia in like everyday activities, so things like writing letters or just group activities, making their way to therapy and things like that. But obviously in a forensic setting there wouldn't be any cognitively healthy patients to take on that sort of peer support roles. I think that's quite a unique thing, but that's the only sort of specific program that I'm aware of from the research I've done so far.
So it sounds as if things are really at the beginning, both in terms of environments and specific approaches in this field.
Yeah, I think it's sort of just like a case-by-case basis at the minute.
Gosh. I suppose when we think of how relatively poor care of people with dementia is in the normal population, it's not really very surprising.
Yeah.
Have you come across anything which suggests that family members are recruited to play a part in the care and support?
I think that's a really interesting question, and that's something that I have had that's a question that I'm asking in my research when I'm interviewing staff. I think it's interesting because in like typical dementia care, the family input in care planning is really important because the family know this person, they know their life history, and all of these sort of things are important for things like therapy and increasing familiarity. But I think with forensic hospitals, and in particular sort of those high security, patients have a limited social network anyway with in regards to like the external family, and especially with high secure settings, because there's only 4 in the UK, a lot of these patients are likely to be quite geographically far away from their family, or they might have limited contact. So yeah, it's something that's interesting, and I'm unsure, and it's something that I've been asking in my data collection phase in my research.
Thank you. And how about the legal system? Again, it may be early days for this, but how does the legal system address the sentencing and parole situation of such patients?
Yeah, I think for what I'm looking at in forensic settings, typically you'd see in terms of dementia, it's something that would develop whilst they're in the hospital. So at the sentencing stage, I'm not sure. But when we're thinking about, how a patient ends up in a secure hospital under mental health legislation, there's principles and like safeguards put in place. So they need to be in a security level that's proportionate to their risk level, and there needs to be an appropriate treatment. And so the Mental Health Act of 1983 and then the one in 2007, I think, that test for appropriate treatment changed. So the old test, and I don't remember the specific terms, but it was something like, is there a treatment that's available for the purpose of preventing deterioration of the disorder? It changed to be, is there a treatment available for the purpose of preventing the deterioration of the disorder or its symptoms? And I think under the old definition, obviously with dementia not being clinically treatable, you're not likely to have someone go into a forensic setting with a primary diagnosis of dementia and the purpose of treating dementia. And under the new treatment test, it's more likely. I think in particular it had like quite an important effect on things like personality disorders, but I don't want to comment too much on that because that's not my area. But I think it's more justifiable to put somebody with dementia in a forensic setting under that new reformed test. But I think from conversations that I've had with forensic staff, it's not likely that somebody would be admitted to a forensic hospital due to dementia. It would normally be either a secondary diagnosis or they develop it whilst in the hospital.
Thank you.
Yeah, that seems most likely, doesn't it, in terms of, I was just thinking, the notion that somebody has dementia is often being offered for reasons why somebody can't be brought to trial because they're not fit to be prosecuted. I was thinking about the staff caring for these people, because like mental health professionals usually choose to specialise in working with a particular client group, and actually if you've chosen to specialise in forensic practice, you're probably choosing not to specialise in older adult mental health care. And for me, I personally wouldn't have chosen to ever work with an older adult population. And I was wondering what that brought up for the staff when they find themselves having to care for people who are developed dementia. That I think a lot of people avoid, maybe just speaking for myself, older adults, that population when there's dementia, because of it forces us to be confronted by our own mortality, I guess, and this idea of deteriorating in quite an unpleasant way. So I wondered what it was like for the staff to be working with this population when it isn't their chosen client group.
Yeah, that's quite an interesting question. It's not something that I've really spoke about with the staff, but I think that's something that would be interesting to find out. I suppose it does introduce sort of new things that they have to deal with, like they're gonna have to start thinking about end of life care or palliative care. I think from the conversations I've had, what they try to do as much as is possible is once that person is, becoming really deteriorating, they are trying to move them away from the forensic setting because it's not appropriate. But because of that forensic label, there are issues and with general dementia services accepting them. So I think that's quite an interesting point, and there is going to be sort of new things that they're going to need to deal with. And because the forensic population is aging, it's gonna continue, and I think dementia prevalence is gonna rise. I think it's just something that is sort of gonna reform forensic mental health care is something that's they're going to have to start thinking about and introducing care pathways and things like that.
I was just thinking, some environments, like we saw the Edenfield scandal last year, I think, or was it the year before, where, it can be difficult for staff to be compassionate in forensic services anyway when they're faced with challenging behaviour. But then if they're also, you spoke about the different stigma, but there is also a different challenge, isn't there, by having to work with people with a population that might have dementia in it. So that could be yet another challenge to compassion that staff might experience, which, sounds like it could be quite a horrible combination of factors really for the patient that's at the midst of that.
Yeah, I think there's been real pushes in dementia care and forensic care separately about increasing a human rights angle to the care of this population and focusing on strength and recovery based approaches rather than relying on restrictive measures, coercive measures, things like that. But I think at the minute there's nothing guiding the intersection between dementia care and forensic care. And so as part of the PhD, I sort of come up with a framework, and I've put it under review at a journal at the minute. It's not published yet, but hopefully it gets published. But yeah, it's sort of talking about that and how staff can have these sort of reactive, risk-averse approaches and how we need to sort of look at it from a different angle with strength and recovery-based approaches.
Do we know much about dementia care for forensic populations in other countries? Are there any countries that are doing it well? Besides, you mentioned the California project, but have you come across any other countries that are managing it better than we are?
So I did a big review of literature when I first started the PhD to see what is actually out there, and there was really minimal research looking at dementia care in forensic hospitals. So other than that one example within California Men's Colony, I'm not really sure. And the majority of the research that I did find was just focused on prevalence rates. So in terms of care pathways, I couldn't find anything. Maybe there is something out there, but not that I'm aware of.
Well, I was just thinking about some of the countries that seem to do certainly custody better, like the Scandinavian countries. They tend to lock less people up anyway, don't they, and get people out more quickly. So I imagine that they probably, on compassionate grounds, would find ways to have people in less secure environments, which sounds like that's the way things should be going, perhaps anyway.
So, I was just reflecting because I have worked at least adjacent to this field some time ago, and that I was working at St Giles Hospital in North Kensington in London at the time when they were closing down all the large mental hospitals on the periphery of London and bringing back the population, and in my case the elderly population, back to new wards in the centre of London, where they came from originally. And so, obviously a somewhat less challenging group of people, I imagine. But nevertheless, I think in terms of the experience for staff and patients as well, the key things are to do with leadership and team cohesion, team training, and just having a very, very open and transparent culture to work in, because otherwise, in no time at all, a darkness falls over a unit and things begin to happen which wouldn't happen in the broad daylight, so to speak.
Yeah.
Do you think? I think you're doing groundbreaking work here, Beth, and it's very important what you're finding out and trying to find out. What ways do you think ICU systems can improve their approach to caring for these elderly inmates with dementia. Now, I know you've got an article under review and you don't want to jeopardise your chance of having it published by broadcasting it to the world, but tell us what you can say.
I think, well, first and foremost, I think there needs to be more awareness about the fact that dementia is likely to be overrepresented in forensic settings. And I think, I don't know, I don't want to talk on behalf of staff, but even for me, when I first saw the advertisement of this PhD, it was something I never even thought about. But when I did start to think about it, I thought that makes sense. Like, there is going to be more people with dementia. So because of that, I think what forensic settings could do is, first of all, they need to start training staff in not just dementia, but all age-related health issues, frailty, sensory deficits, dementia, things like this, because the population is aging. Because I think there needs to be better, like, training would help with identification, but there needs to be better screening processes as well. So at the minute, there's not routine cognitive screening. Instead, screening or like these processes for assessment are based on clinical suspicion. So I think obviously it would be expensive, but I think if we started like annually screening older patients, you're more likely to identify dementia at an earlier stage and get these early interventions in. But that being said, the screening tools currently used for dementia, there's many different ones. There's like the mini mental state examination, the MOCA, the Adam Brooks cognitive examination. They're based on general dementia samples, so that they could be not so applicable to the forensic context. So maybe there needs to be a forensic screening tool for dementia. In terms of care pathways, I think there needs to be a standardised care pathway, but also there needs to be consideration of the kind of psychological therapies that patients are undergoing. So there'll be patients that are doing offence-focused work, or they might be some interventions might be quite highly intensive and require like high integrity, high consistency, high engagement. I think sex offender programs are quite characterised by that. Patients with dementia might not be able to engage in these kind of therapies anymore. Sort of being aware of that, maybe introducing dementia-specific therapies. So under guidelines, there's recommendations for things like cognitive stimulation therapy, cognitive rehabilitation therapy, reminiscence therapy. It could be that introducing therapies like this could be quite beneficial. What else? I think just sort of having these strength and recovery focused approaches, and also risk assessment tools is another thing. Obviously with dementia, it can increase and decrease risk. So it can decrease risk because we'll see dementia typically with an older population, so they are more frail and their actual physical ability to carry out much harm is going to be decreased. But then on the other hand, it can increase risk because you'll see more, symptoms like disinhibition or loss of empathy, more impulsiveness. So I think maybe risk assessment tools need to sort of take into account these kind of considerations as well.
Great, thank you. So this is an open question, Beth. So what would you like to tell us about the work that you're doing and how you'd like to see it progress?
I think, so I'm looking at specific hospitals, and at the end of the research I'm hoping to have some recommendations and hopefully it would improve those specific hospitals. But I think I'm really keen to get research published and out there because there's not much at the minute. So just open up the idea of investigating and exploring what's going on in regards to dementia care at the minute, and just hopefully make more people aware about it. I'm also at the minute, I'm doing another big literature review where I'm looking at dementia-friendly environments, and I'm going to try to see what kind of things we can do to introduce into forensic environments to make them more dementia-friendly. Obviously, that's going to be idealistic, and in reality, it's going to be, there's going to be security measures that are in place that are going to restrict the kind of dementia-friendly things that we can incorporate into forensic settings. But that's another thing, I think, is looking at how we can make these settings more dementia-friendly.
Thank you. So this was an advertised PhD post, so you deliberately applied for it, which I suppose is saying something about you. And nevertheless, working in the high secure system is always challenging, isn't it? How do you keep yourself going and emotionally healthy?
Yeah, that's a good question. I think because this is like an interest of mine, I think just sort of keeping myself grounded and knowing that the reason I'm doing it and what I'm doing is to help a population that is marginalised and it is underrepresented. But also, I think for me, what really helps me is having a really good social network. So I've got really amazing supervisors, and at my university as well, we have a really big PhD community. So all of my friends are also doing PhDs. Obviously, they're not doing the same topic as me, but they're also doing quite emotionally rich topics like dementia or well-being in young people. So I think just making sure that I've got a social network, supportive social network, and making sure to take breaks as well, which I think a lot of PhD students struggle with. But I always make sure to have my breaks.
Well, thanks very much indeed for coming along and telling us about this work that you're doing today, Beth.
Yeah, really interesting stuff, and hopefully we might get another conversation with you when you've finished and you've got clear recommendations to be making as well that could benefit other services to hear. Thank you.
Thank you. Thanks for having me on, and it was lovely to meet you both as well.
Thank you.